Tell me about yourself.
My name is Mihiraa, and I am a dedicated and compassionate nurse with a strong commitment to delivering high-quality patient care. I completed my Bachelor of Science in Nursing, BSN, from King George's Medical University, where I gained a solid foundation in clinical practice, patient assessment, and evidence-based care. During my academic years, I actively participated in hands-on training across various departments, including medical surgical, pediatrics, and critical care, which helped me develop adaptability and a patient-centered approach. Following my graduation, I began my professional journey at Apollo Hospital, where I worked as a registered nurse in the emergency department. In this role, I managed diverse patient cases, collaborated with multidisciplinary teams, and ensured adherence to international healthcare standards. My experience includes administering medications, monitoring vital signs, providing wound care, and educating patients and families on post-treatment care, all while maintaining empathy and professionalism in high-pressure environments. One of my most rewarding experiences was working in neonatal intensive care, where I honed my critical thinking and quick decision-making skills. I also took the initiative to mentor junior nurses, reinforcing my leadership abilities and passion for teamwork. Looking ahead, my career goal is to further specialize in critical care nursing while pursuing advanced certifications such as ACLS and a master's in nursing. I am particularly interested in contributing to healthcare settings that prioritize innovation, patient safety, and holistic care. Ultimately, I aspire to grow into a senior nursing role where I can mentor others and drive positive changes in patient outcomes. I am excited about the opportunity to bring my clinical expertise, dedication, and continuous learning mindset to your esteemed organization and make a meaningful impact on the lives of patients.
Why did you choose nursing as a career?
From a young age, I have always been drawn to caring for others, whether it was helping a family member recover from an illness or comforting a friend in distress. This innate desire to make a meaningful difference in people's lives led me to pursue nursing as a career. What solidified my decision was witnessing the profound impact nurses have on patients, not just through medical treatment but also through compassion, advocacy, and emotional support. During my early exposure to healthcare, I admired how nurses combined scientific knowledge with empathy to guide patients through their most vulnerable moments. Nursing, to me, is more than a profession, it's a calling that allows me to use both my critical thinking skills and my ability to connect with people on a deeply human level. The dynamic nature of the field, where no 2 days are the same, also excites me because it offers continuous learning and growth. Ultimately, I chose nursing because it aligns with my core values of service, resilience, and lifelong learning. Every day, I have the privilege of not only healing but also empowering patients, which is incredibly fulfilling. I can't imagine a more rewarding career.
Why did you decide to become an LPN specifically?
I chose to become a licensed practical nurse because I wanted to enter the nursing profession with a strong clinical foundation while making an immediate difference in patient care. The LPN path appealed to me as it provided an efficient yet comprehensive route to begin hands-on nursing practice, allowing me to develop essential bedside skills and gain real-world experience more quickly than a longer degree program might allow. What particularly drew me to the LPN role was its balance of direct patient interaction and technical responsibilities, from administering medications to monitoring vital signs and providing compassionate bedside care. I appreciated that LPNs serve as a crucial bridge between patients, RNs, and healthcare teams, often forming close therapeutic relationships while working closely under RN supervision to ensure quality care. Additionally, becoming an LPN aligned with my goals at the time, it allowed me to start contributing to healthcare sooner while keeping the door open for future advancement. Now, as I gain experience, I'm even more motivated to eventually pursue my RN or specialize further, using my LPN background as a springboard for growth. The role has reinforced my passion for nursing, and I'm grateful for the solid clinical foundation it's given me.
What aspects of the LPN role appeal to you the most?
What I find most rewarding about the LPN role is the unique balance of hands-on clinical care and meaningful patient connections. As an LPN, I thrive in the immediacy of care, whether it's closely monitoring a patient's condition, administering treatments, or providing comfort during vulnerable moments. The role allows me to combine technical skills like wound care or medication management with the human side of nursing, where active listening and patient education make a tangible difference in someone's recovery. I also deeply appreciate the collaborative nature of the LPN position. Working alongside RNs, physicians, and other healthcare professionals gives me the opportunity to learn while contributing my own observations and insights to the care team. It's a role that values both autonomy in executing tasks and teamwork in achieving patient outcomes. Finally, the LPN role offers a dynamic work environment, whether in long-term care, clinics, or hospitals, where I can adapt to diverse patient needs every day. This variety keeps me engaged and continuously growing as a nurse, reinforcing my passion for the profession.
What are your long-term career goals in nursing?
My long-term career goals center on expanding my clinical expertise, taking on leadership responsibilities, and contributing to advancements in patient care. In the coming years, I plan to bridge from my LPN role to becoming an RN by pursuing my Bachelor of Science in Nursing, as I'm deeply committed to growing my scope of practice and taking on more complex patient care responsibilities. Beyond licensure advancement, I'm particularly drawn to specializing in gerontology, where I can combine hands-on skills with specialized knowledge to improve outcomes for vulnerable populations. I intend to obtain certifications to enhance my ability to deliver evidence-based care. Ultimately, I aspire to move into roles that allow me to mentor new nurses and improve care systems, whether as a charge nurse, clinical educator, or unit supervisor. What drives me is the opportunity to elevate not just my own practice, but also to positively influence healthcare delivery through leadership, policy input, or quality improvement initiatives. Nursing is a lifelong learning journey, and I'm excited to grow alongside the evolving needs of patients and the healthcare field.
Where do you see yourself in 5 years?
In 5 years, I envision myself as an experienced registered nurse with specialized certifications in specific area, e.g., critical care, oncology, or infection control, delivering advanced clinical care while mentoring newer nurses. Having transitioned from my LPN foundation, I aim to be working in a hospital/clinic/home health setting where I can combine hands-on patient care with leadership responsibilities, whether as a charge nurse, preceptor, or participating in unit-based councils to improve protocols. Professionally, I plan to have completed my BSN and be enrolled in or considering a master's program to prepare for roles like clinical nurse specialist or nurse educator, depending on where my passion leads me. Most importantly, I see myself continuing to grow as an advocate for patients, staying at the forefront of evidence-based practice, and contributing to a healthcare team that prioritizes both excellence and compassion. Nursing is dynamic, so while I have clear goals, I'm also open to evolving with new opportunities in the field.
What are your strengths as a nurse? Can you provide specific examples?
One of my greatest strengths is my ability to combine clinical precision with compassionate patient advocacy. For example, while working in a busy post-surgical unit, I noticed an elderly patient showing subtle signs of delirium, restlessness, and slight confusion that others had attributed to normal recovery. Because I prioritize thorough assessments, I recognized these as early red flags, promptly notified the physician, and implemented non-pharmacological interventions like reorientation and family involvement. This prevented escalation and reduced the patient's hospital stay by 2 days. Another strength is my adaptability in high-pressure situations. During a night shift in the ER, we received multiple trauma cases simultaneously. While assisting an RN with a critical patient, I simultaneously managed a pediatric asthma case by calmly administering nebulizers, monitoring oxygen saturation, and coaching the child through breathing exercises, all while ensuring accurate documentation. My ability to prioritize and multitask without compromising care quality helped stabilize both patients efficiently. Lastly, I excel at patient education, which I believe is transformative. With a diabetic patient reluctant to insulin therapy, I took time to break down misconceptions using visual aids and culturally sensitive analogies. By their discharge, they could confidently self-administer injections and verbalize warning signs of hyperglycemia, a victory noted by our endocrinology team. These experiences reinforce that my strengths lie in vigilant assessment, grace under pressure, and empowering patients, all grounded in evidence-based practice.
What are your weaknesses? How are you working to improve them?
One area I've been actively working to improve is my tendency to take on too many tasks independently before seeking support. Early in my career, I sometimes hesitated to delegate because I didn't want to burden colleagues during busy shifts. For example, during a particularly hectic day in the Med-Surg unit, I realized I'd fallen behind on charting while trying to manage multiple patient discharges alone. This taught me that teamwork is essential for both efficiency and patient safety. To address this, I've implemented two strategies. First, I now proactively communicate with my team during shift handoffs to identify tasks that can be shared. Second, I've set reminders to pause hourly and assess whether I should request assistance or reprioritize. Over the past year, this approach has helped me maintain better work-life balance while actually strengthening my collaboration skills. Another challenge I've recognized is my discomfort with public speaking, which became apparent when asked to lead a small in-service on wound care protocols. To improve, I've been volunteering to present case studies during our monthly staff meetings, starting with brief 5-minute summaries and gradually increasing complexity. I've also joined a nursing mentorship program where I practice explaining concepts to students, which builds both my confidence and teaching abilities. What's important to me is that I don't just identify weaknesses, but create measurable plans to transform them into growth opportunities. These efforts have already shown results in my daily practice and professional development.
Why are you interested in working at our facility? What do you know about us?
I'm particularly drawn to your facility because of its reputation for innovative approaches to geriatric medicine, which aligns perfectly with my professional values and clinical interests. From my research, I was impressed to learn about your magnet designation and low nurse-to-patient ratios in the ICU. What stands out to me most is your commitment to integrating evidence-based practice with compassionate care. For example, I read about your falls prevention program that reduced incidents by 30% last year. This demonstrates to me that this is an organization where I can grow as a nurse while contributing to meaningful patient outcomes. Having trained at University Hospital, I've developed skills in emergency care and critical thinking that I believe would complement your team's approach to patient-centered care. I'm especially excited about the opportunity to work with your diverse patient population and collaborate with your interdisciplinary team to enhance quality metrics. This feels like an environment where my passion for clinical excellence would thrive, and where I could both contribute meaningfully and continue developing as a healthcare professional.
What motivates you in your work as a nurse?
What truly motivates me in nursing is the profound privilege of being present during life's most vulnerable moments and making a tangible difference through both clinical expertise and human connection. Nothing compares to seeing a patient progress from critical illness to recovery, or helping someone manage a chronic condition with renewed confidence. These transformations fuel my passion daily. I'm particularly driven by the intellectual and emotional challenges of nursing. Every case requires critical thinking to solve clinical puzzles, but also demands compassion to address fears and uncertainties. For example, when I helped a first-time mother through a complicated delivery, it wasn't just about monitoring vitals, it was about explaining each step to ease her anxiety, which ultimately led to a safer delivery. That balance of science and heart is what makes nursing so uniquely rewarding. Additionally, I thrive on the collaborative nature of our work. The way nurses, doctors, therapists, and families come together to create individualized care plans inspires me to keep learning and contributing. Even on difficult days, knowing our team's efforts directly impact someone's quality of life, whether through pain management, education, or simply holding a hand, reaffirms why I chose this profession. My motivation comes from those countless small moments that collectively define extraordinary care.
How do you handle stress and pressure in a fast-paced environment?
In high-pressure situations, I rely on a combination of structured prioritization and mindful resilience, skills I've honed through experience in fast-paced units like the ER and step-down ICU. My approach begins with the ABCs of nursing, quickly assessing which tasks are urgent like airway management or critical meds versus important but less time-sensitive like documentation updates. For example, during a sudden influx of post-op patients with pain crises at Apollo Hospital, I systematically triage needs by acuity while ensuring safety checks weren't rushed. I've learned that clear communication is my most powerful tool under stress. I actively brief teammates when delegating. I'll handle these 2-4 starts. Can you prep the wound care cart, and use closed-loop communication to prevent errors? After particularly demanding shifts, I reflect on what went well and where processes could improve, which helps me grow more efficient with each challenge. To maintain resilience, I practice brief mindfulness techniques, even just 30 seconds of focused breathing between patients, to reset mentally. I also prioritize self-care outside work through regular exercise and nursing peer support groups. What keeps me grounded is remembering that pressure in healthcare often means someone truly needs my skills at their best. That perspective turns stress into purpose.
Describe your experience with patient hygiene.
Providing comprehensive hygiene care has been a fundamental part of my nursing experience across multiple settings, from long-term care to acute hospital units. I approach hygiene not just as a task, but as an essential component of dignity, comfort, and infection prevention. In my current role at University Hospital, I routinely perform complete bed baths for immobilized patients, paying special attention to skin folds and pressure points to prevent breakdown. With conscious patients, I always explain each step. I'm going to help you wash your face now with this warm cloth, which maintains their autonomy despite their limitations. One memorable case involved a terminal cancer patient who found profound comfort in hand massages during bed baths. This small act became our therapeutic ritual that eased her anxiety. For oral care, I'm meticulous with unconscious patients, using suction toothbrushes and moisturizing lips every 2 hours to prevent ventilator-associated pneumonia. With dementia patients in my previous LTC role, I adapted techniques like hand-underhand guidance to help them participate in brushing their teeth. I'm particularly attentive to pericare for incontinent patients, always using pH-balanced cleansers and barrier creams tailored to individual skin needs. When caring for a bariatric patient with limited mobility, I collaborated with PT to develop a turning schedule that allowed thorough cleaning while preventing shear injuries. Beyond technique, I view hygiene moments as opportunities to assess for changes, noting early candidiasis during mouth care or detecting a stage I pressure injury during a bath that might have been missed otherwise. These routine interactions often become my most clinically revealing assessments.
Tell me about a time you had to prioritize multiple patient needs. How did you handle it?
During a night shift in the medical surgical unit, I faced a situation that required careful prioritization when 3 of my patients had urgent needs simultaneously. My post-op hip replacement patient spiked a fever of 102.3 degrees Fahrenheit, my diabetic patient became diaphoretic with a blood glucose of 52 mg per deciliter, and my dementia patient with a UTI began pulling at her Foley catheter. I immediately used the ABC, airway breathing circulation, framework to triage. Recognizing hypoglycemia as the most immediately life-threatening, I prioritized my diabetic patient first. While rushing to her room, I called the CNA to bring orange juice and alerted the charge nurse about my other patients. After confirming the patient could swallow safely, I administered 15 g of fast-acting carbs and stayed to monitor her response while simultaneously preparing glucagon as backup. Once her glucose stabilized at 85 mg per deciliter, I quickly assessed my febrile post-op patient. Noting his fever but stable vitals, I administered prescribed acetaminophen, initiated a cool compress, and flagged his chart for the on-call resident to review potential infection, but deferred a full workup until addressing my third patient. The dementia patient required gentle redirection and a temporary mitt to prevent catheter dislodgement, after which I could properly reassess her for discomfort or infection. Throughout this process, I first documented interventions in real time using the bedside computer to avoid memory errors. Second, updated the charge nurse every 15 minutes for situational awareness. Third, returned to all 3 patients within 30 minutes for reevaluation. The outcome was positive, all patients stabilized without complications. This experience reinforced how dynamic prioritization, clear communication, and systematic follow-ups are critical in managing competing demands.
Describe your experience with electronic health records, EHR, systems.
Throughout my nursing career, I've become proficient in multiple EHR systems, including Epic, Cerner, and Meditech, across both hospital and clinic settings. I've used these platforms not just for basic documentation, but as a critical tool to enhance patient safety and interdisciplinary collaboration. In my current role at hospital/clinic name, I leverage Epic's integrated dashboard to efficiently monitor my entire patient assignment, tracking real-time vitals, pending labs, and medication schedules at a glance. For example, I created personalized quick links for frequent tasks like wound care documentation, which reduced my charting time by 20% while improving detail in progress notes. I'm particularly diligent about using structured data fields for allergies and medication reconciliation, having caught several potential interactions through the system's alert features. I also actively participate in our unit's EHR optimization committee. After noticing nurses were duplicating flowsheet entries, I helped redesign our documentation workflow, which saved our 30-bed unit approximately 15 collective hours per week. For patient education, I frequently use embedded teaching modules that automatically document compliance and generate follow-up reminders. During transitions between facilities, I've adapted quickly to new systems. Within 2 weeks at my last travel assignment, I achieved 100% chart audit compliance in an unfamiliar Cerner environment by studying its medication administration record, MAR, quirks and customizing my own verification checklist. What I value most about EHRs is their potential to connect care teams. I routinely use secure messaging to clarify orders with providers and flag critical changes for oncoming shifts through standardized handoff tools. My goal is always to use technology to make care safer, never letting it replace bedside presence. I document in the room whenever possible to verify accuracy with patients themselves.
How do you ensure accuracy when administering medications? What steps do you take?
Medication administration demands unwavering attention to detail, and I approach every dose with a systematic process grounded in the 5 rights: right patient, right medication, right dose, right route, and right time, while also incorporating additional safety checks. My protocol begins with verifying the patient's identity using 2 unique identifiers, typically their full name and date of birth, while also cross-referencing their wristband with the EHR. I then carefully review the medication order in the system, paying close attention to any allergies, contraindications, or special instructions, such as holding a blood pressure medication if the patient's systolic is below a certain threshold. Before preparing the medication, I double-check the label against the MAR, medication administration record, confirming the correct dosage, form, and expiration date. For high-alert medications like insulin or opioids, I involve a second nurse for independent verification, as per facility policy. During administration, I stay mindful of the route, whether oral, or subcutaneous, and follow best practices, such as scanning barcodes when available or using non-dominant hand techniques for 4 pushes to avoid errors. I also prioritize patient education, explaining the purpose and potential side effects of each medication, which often serves as a final safety check. For instance, if a patient mentions they usually take a small white pill, but I'm holding a blue tablet, I pause to investigate further. After administration, I document immediately in the EHR, noting the time, dose, and any patient reactions, and I monitor for therapeutic effects or adverse responses. Beyond these steps, I cultivate a just culture mindset. If I encounter a near miss or error, I report it transparently to contribute to systemic improvements. This disciplined yet holistic approach ensures that medication safety remains a non-negotiable priority in my practice.
What is your approach to assessing a patient's condition and reporting changes to the RN or physician?
My approach to patient assessment is systematic and patient-centered, blending structured clinical evaluation with ongoing surveillance for subtle changes. I begin every shift with a comprehensive head-to-toe assessment, using a standardized framework like ABCDE, airway, breathing, circulation, disability, exposure, to ensure nothing is overlooked. For example, when assessing a post-operative patient, I don't just check vital signs, I evaluate surgical site integrity, pain levels, and emotional state, recognizing that anxiety can mask early signs of complications. I prioritize trend analysis over single data points. If a patient's blood pressure is trending downward even within the normal range, or if their urinary output has gradually decreased over 2 shifts, I document these changes with precise metrics and compare them to their baseline. I've found that using tools like the Modified Early Warning Score, (MUSE), helps objectively quantify when a patient's condition warrants escalation. When reporting changes, I use the ISBAR format: introduction, situation, background, assessment, recommendation, readback, to ensure clarity and urgency. For instance, when calling a physician about a COPD patient with increasing work of breathing, I'd say, "This is Mihiraa, RN, calling about Mr. Lee in room 412. His SpO2 has dropped to 88% on 2-LNC despite being 92% an hour ago. He has a history of emphysema and was admitted for exacerbation. I've already elevated the HOB and switched to a Venturi mask at 35%, but he still appears distressed. I recommend considering ABGs and possibly BiPAP. Can you confirm those orders?" This method keeps reports focused and actionable. Between formal assessments, I practice intentional rounding, using every patient interaction, medication passes, turning, as an opportunity to reassess. I once identified impending sepsis in a post-op patient not through vital signs but by noticing his quieter-than-usual demeanor during morning care, a subtle change his family later confirmed was unusual. Ultimately, my goal is to function as the surveillance system for the care team, distinguishing between expected variations and true clinical deterioration. I take pride in catching changes early but also in knowing when to trust my assessment enough to advocate assertively for the patient.
Describe a time you identified a potential safety risk for a patient. What did you do?
During a night shift in the cardiac step-down unit, I noticed a potential safety risk while administering medications to a patient recovering from heart failure. As I scanned the barcode for their scheduled diuretic, the EHR alerted me to a potassium level of 3.2 milliequivalent/L from that afternoon's labs, a result that hadn't yet been flagged by the system or addressed in the progress notes. The patient was prescribed both a loop diuretic and digoxin, creating a high-risk scenario for arrhythmias if hypokalemia wasn't corrected. I immediately paused the medication administration and performed a focused assessment, checking for muscle weakness or irregular pulse. The patient reported new fatigue and exhibited occasional PVCs on telemetry. Using the ISBAR framework, I contacted the covering physician. "This is Mihiraa calling about Mr. D in 512. His potassium is 3.2, he's on 40 mg furosemide BID and digoxin 0.125 mg daily. I'm seeing PVCs on telemetry and he reports new fatigue. I recommend holding the PM diuretic dose and initiating potassium replacement per protocol." The physician agreed and ordered for potassium supplementation. While preparing the infusion, I placed the patient on continuous telemetry monitoring, educated them about potassium-rich foods, and updated the day shift to ensure repeat labs would be drawn. Later, I participated in a debrief with our unit manager that led to a new process for real-time electrolyte alerts in the EHR. This experience reinforced how vigilance at the point of care, even with routine medications, can prevent critical incidents. It also highlighted the importance of speaking up assertively when protocols need reevaluation to enhance patient safety.
How do you handle a situation where a patient's condition is rapidly declining?
When faced with a rapidly deteriorating patient, I immediately implement a structured approach centered on the ABC, airway breathing circulation, framework while simultaneously activating emergency protocols. For example, while caring for a post-operative patient who suddenly became tachycardic, HR 140, and hypotensive, BP 80/50, I first ensured their airway was patent, then administered supplemental oxygen via non-rebreather mask while calling for the rapid response team. Recognizing early signs of hemorrhagic shock, I positioned the patient in Trendelenburg, initiated 4 fluid resuscitation per standing orders, and urgently paged the surgeon using the ISBAR format. This is Mihiraa in room 312, post-op laparotomy patient with 30-point BP drop over 15 minutes, pale and diaphoretic, suspect internal bleeding, request stat CBC and surgical review. During such crises, I prioritize 3 simultaneous actions. First, direct patient interventions, e.g., starting CPR if pulseless. Second, team coordination, assigning roles like, you document, you prepare meds. Third, information management, briefing responders with concise, relevant data. After stabilizing a recent septic shock patient, I conducted a personal debrief to identify system gaps, realizing our unit needed clearer sepsis alert checklists. This led to implementing a Time Zero documentation tool that reduced our sepsis recognition time by 40%. My approach balances rapid clinical response with structured communication, ensuring every second counts while maintaining situational awareness for the broader care team.
Tell me about your experience with different patient populations, e.g., geriatrics, pediatrics, long-term care.
My clinical background has given me the privilege of caring for diverse patient populations, each requiring tailored approaches to meet their unique needs. In geriatric care, particularly during my time in a post-acute rehabilitation unit, I became skilled at managing complex comorbidities while preserving dignity. For example, I implemented a falls prevention strategy for dementia patients that combined hourly rounding with personalized mobility plans, reducing incidence by 35% over 6 months. I'm particularly attentive to subtle changes in elderly patients, recognizing that confusion might signal a UTI before lab results return, or that just not eating well could indicate silent aspiration. With pediatric patients, I've worked in outpatient clinics where building trust was as crucial as clinical skills. I adapted assessment techniques, using play therapy to examine toddlers or the FACES scale for pain assessment in nonverbal children. One memorable case involved a diabetic adolescent struggling with compliance. By creating a gamified glucose tracking system with their input, we improved their A1C from 9.2% to 7.1% in 3 months. My long-term care experience taught me the importance of holistic chronic disease management. For COPD patients, I coordinated with respiratory therapists to develop breathing exercise routines that reduced hospital readmissions. I also became proficient in family education, especially for caregivers managing stage 4 pressure injuries at home. Most recently, in the emergency department, I've honed rapid assessment skills across all ages, from neonates with febrile seizures to trauma victims in their 90s. This environment reinforced my ability to adjust communication styles instantly, whether explaining procedures to a frightened child or discussing goals of care with a terminally ill patient's family. What unites my approach across populations is meeting patients where they are, physically, emotionally, and developmentally, while maintaining rigorous clinical standards. I'm particularly drawn to critical care nursing, where I can apply this breadth of experience to enhancing patient outcomes through evidence-based interventions and interdisciplinary collaboration.
How do you stay updated on current nursing practices and advancements?
Staying current in nursing is both a professional responsibility and a personal commitment to my patients, so I take a multifaceted approach to continuous learning. I maintain active memberships in the American Nurses Association and Sigma Theta Tau, which gives me access to their peer-reviewed journals like the American Journal of Nursing and Evidence-Based Nursing. Every month, I dedicate time to reviewing at least 2 clinical studies. Recently, I've been focusing on updates to sepsis protocols and early mobility in ICU patients, which I've since incorporated into my practice. I also leverage technology for microlearning. I subscribe to nursing podcasts like Straight A Nursing during my commute and follow clinical experts on LinkedIn who break down complex topics, such as the latest WHO guidelines on infection prevention. At work, I participate in our unit's journal club where we analyze new research. Last quarter, we implemented a modified catheterization technique from a BMJ study that reduced our CAUTI rates by 20%. When encountering unfamiliar situations, I use point-of-care resources like UpToDate to verify best practices in real time. I recently completed an AACN-sponsored course on advanced cardiac life support updates, and I'm currently pursuing certification in oncology nursing to deepen my expertise. Most importantly, I learn daily from my colleagues, whether it's a veteran nurse sharing a time-tested technique or a new graduate introducing a fresh perspective from recent training. This blend of formal education, peer collaboration, and digital resources ensures my practice remains both evidence-based and patient-centered.
Describe your experience with infection control protocols.
Infection prevention has been a cornerstone of my practice across every clinical setting I've worked in. I approach it as both a science and a culture, requiring strict adherence to protocols while fostering team accountability. In my current role at Apollo Hospital, I've implemented several evidence-based strategies that go beyond basic compliance. For standard precautions, I practice clean to dirty workflows instinctively, whether it's moving from four-site care to wound dressing changes or systematically disinfecting equipment between patients. During the COVID-19 pandemic, I helped redesign our donning/doffing station for PPE, reducing contamination errors by 40% through visual guides and peer audits. My meticulous approach to hand hygiene includes washing for the full 20 seconds even during emergencies, and I've been known to gently remind colleagues with a "clean hands for this patient?" prompt when needed. With isolation cases, I balance safety with dignity. For a MRSA-positive burn patient, I created a hygiene clock system, coordinating wound care, linen changes, and environmental cleaning in one visit to minimize room entries while ensuring 2-hour turns. I'm particularly vigilant about high-touch surfaces. I once identified that our portable vital signs machine's cords were being overlooked in terminal cleaning, leading to a new disinfection protocol. Beyond daily practice, I've participated in infection control committees where we analyzed CLABSI rates to introduce chlorhexidine-impregnated dressings, trained staff on proper PPE sequencing for Ebola/Mpox scenarios, developed a antibiotic stewardship quick guide for nurses to recognize overuse. What sets my approach apart is viewing infection control not as a checklist, but as continuous situational awareness, whether it's spotting a visitor about to touch a sterile field or recognizing that a patient's new fever might require contact precautions. This mindset, combined with data-driven improvements, helps protect both patients and staff.
How do you build rapport and trust with patients and their families?
Building trust begins with recognizing that every patient and family enters the healthcare environment with unique fears, expectations, and cultural perspectives. My approach centers on consistent presence, active listening, and transparency, qualities I've honed across diverse settings from pediatric clinics to geriatric hospice care. With patients, I establish connection from the first encounter by meeting them at eye level, literally sitting beside the bed for conversations, and using open-ended questions like, "What's most important for us to address today?" rather than rushing into clinical tasks. For example, with a reluctant diabetic adolescent, I spent our first visit discussing his basketball routine before gradually linking nutrition to his athletic performance. By our third session, he was voluntarily logging his carb intake. For families, I practice teach back with empathy. After explaining a treatment plan, I'll ask, "How does this fit with what you were expecting?" to uncover unspoken concerns. When a daughter struggled with her mother's dementia behaviors, I created a trigger diary to identify patterns while validating her caregiver stress. This collaborative problem-solving built enough trust that she later consented to needed respite care. In high-stakes situations like ICU, I provide predictable updates. Even when there's no change, I'll say, "Her vitals remain stable. We're watching the 4 p.m. labs closely to reduce anxiety." With non-English speakers, I go beyond interpreters by learning key phrases in their language and using visual aids for consent discussions. What sustains these relationships is following through on small promises, whether it's returning at a specific time to reposition a patient or ensuring a family's spiritual leader can visit. These deliberate actions create a foundation where patients and families feel safe to voice concerns, making care truly collaborative.
Describe a time you had to communicate difficult information to a patient or family member. How did you handle it?
One of the most profound moments in my career was guiding a family through the transition to comfort care for their 82-year-old matriarch with end-stage heart failure. The daughter, who held medical power of attorney, was understandably overwhelmed when the cardiology team determined curative treatment was no longer effective. I requested a private family meeting in the quiet room, ensuring tissues, water, and chairs were arranged to facilitate a supportive environment. Before discussing medical details, I asked the daughter, "What has your mother's journey with this illness been like for your family?" This revealed their cultural belief that giving up would dishonor their mother, a perspective crucial to address. Using the Spikes protocol: setting, perception, invitation, knowledge, empathy, summary, I first paced information by first confirming their understanding of her prognosis. Second, avoided euphemisms while remaining compassionate. The treatments are no longer slowing her heart's decline, rather than, "There's nothing more we can do." Third, validated emotions by saying, "This isn't the outcome any of us wanted for her." Fourth, offered guided choices. "We can focus on ensuring her comfort and dignity. Would you like to discuss what that might look like?" When the daughter asked, "Are we killing her by stopping the 4 meds?" I explained the natural dying process and reassured her that comfort measures actively treat symptoms like pain or breathlessness. I arranged for the palliative team to demonstrate morphine administration, emphasizing it was for air hunger, not sedation. Over the next 48 hours, I became their consistent point of contact, providing hourly updates, facilitating spiritual care visits, and even creating a memory box with handprints. At discharge, the family thanked me for helping them do right by Mom, which underscored how truthful yet tender communication can transform traumatic moments into meaningful ones.
How do you advocate for your patients' needs and preferences?
Patient advocacy is the foundation of my nursing practice. It's where clinical expertise and human connection intersect to ensure care aligns with what matters most to the individual. I approach advocacy through a framework of active listening, cultural humility, and persistent communication across all levels of the healthcare team. One example that encapsulates this occurred with a terminally ill patient from a culture where discussing death was considered taboo. While the medical team focused on aggressive treatment, I noticed the patient withdrawing during rounds. During my evening assessment, I sat with him and asked, "What does a good day look like for you now?" He shared that pain control and seeing his grandchildren mattered more than prolonged hospitalization. Recognizing this disconnect, I arranged a family meeting with the palliative care team, serving as both interpreter of his unspoken wishes and mediator when relatives initially resisted comfort care. By reframing the conversation around honoring his priorities rather than stopping treatment, we developed a plan for home hospice with dedicated symptom management, allowing him his final days surrounded by family. In daily practice, I advocate through deliberate actions, verifying consent with teach-back methods for non-native speakers, creating visual pain scales for patients with cognitive impairments, and escalating concerns using structured tools like ISBAR when a patient's subtle decline isn't yet reflected in vitals. I've also championed system-level changes, such as implementing a My Voice whiteboard in rooms where patients document daily goals, a simple tool that reduced call bell usage by 25% while improving satisfaction scores. True advocacy means speaking up even when it's uncomfortable, whether reminding a rushed provider to sanitize their hands before an exam or challenging visiting hour policies that separate neonates from exhausted mothers. My measure of success is seeing relief in a patient's eyes when they realize, this team truly sees me as a person, not just a case.
How do you handle a patient who is anxious or uncooperative?
When faced with an anxious or uncooperative patient, I approach the situation with a combination of empathy, active listening, and clinical reasoning to identify the root cause of their distress. My priority is to de-escalate tension while maintaining their safety and dignity, recognizing that resistance often stems from fear, pain, or a sense of lost control. For instance, I once cared for an elderly dementia patient who became combative during wound care, shouting and pushing staff away. Rather than insisting on the procedure, I paused and knelt to meet her at eye level, speaking in a calm, reassuring tone. I noticed her clutching a family photo, so I used reminiscence therapy, asking about the people in the picture. As she grew more engaged, I slowly introduced each step of the wound care. May I clean your leg now? This might feel cool, while allowing her to hold the photo for comfort. By giving her choices, should we change the dressing before or after your lunch? And breaking tasks into smaller steps, we completed the procedure without restraint or sedation. In cases of acute anxiety, such as a panic attack before surgery, I employ grounding techniques like the 5-4-3-2-1 method, guiding the patient to name 5 things they see, for they can touch, and so on, to redirect their focus while administering prescribed anxiolytics if needed. With pediatric patients, I use play therapy. For a terrified 6-year-old needing 4 access, I had him practice on a stuffed animal first while blowing bubbles to regulate his breathing. Crucially, I assess for underlying triggers, uncontrolled pain, medication side effects, or cultural misunderstandings. A seemingly uncooperative migrant worker once refused vital medications until I discovered through an interpreter he believed they'd interfere with his ability to work. By collaborating with the care team to adjust timing and explaining the purpose in relation to his goal, he became fully compliant. Throughout these interactions, I maintain clear boundaries with kindness. I understand this is hard, but hitting isn't safe. Let's try squeezing this stress ball instead. Post-incident, I document behavioral patterns and effective strategies to ensure continuity of care. My goal is always to transform resistance into collaboration by honoring the patient's autonomy while delivering medically necessary care.
How do you ensure patient privacy and confidentiality? Protecting patient privacy and confidentiality is a fundamental ethical obligation that I integrate into every aspect of my practice, both technically and interpersonally. I approach this responsibility through a combination of strict protocol adherence, environmental awareness, and cultural sensitivity to ensure compliance with international standards like HIPAA and GDPR, as well as institutional policies. In clinical settings, I maintain discretion by always verifying patient identities before discussing their care and ensuring conversations about sensitive health matters occur in private spaces, never at nursing stations or public corridors. For instance, when updating a family about a patient's HIV status, I escorted them to a consultation room rather than speaking at the bedside where others might overhear. With electronic records, I practice rigorous cybersecurity habits, never sharing login credentials, double-checking that I've selected the correct patient chart before documenting, and ensuring computer screens face away from public view. I also advocate for privacy during interdisciplinary handovers by summarizing sensitive details discreetly instead of announcing, Mr. Khan's psychiatric evaluation shows. In a shared space, I'll note asterisk. Let's review his 10 a.m. assessment in the report. Asterisk. Beyond physical and digital safeguards, I respect cultural dimensions of privacy. While working in a conservative community, I learned female patients preferred same-gender caregivers for personal care, a preference I honored by coordinating staff assignments accordingly. For adolescents requesting confidential sexual health services, I followed our facility's minor consent protocols while providing non-judgmental education. When breaches occur, like an accidental fax to an incorrect number, I immediately report them through proper channels and participate in root cause analyses to prevent recurrence. My commitment extends to mentoring peers. I once noticed paper charts left unattended and initiated a unit-wide clean desk policy with locked storage bins. Ultimately, I view confidentiality not just as a legal requirement, but as a covenant of trust. Patients share their most vulnerable moments with us, and I safeguard that privilege through constant vigilance in both action and attitude. Describe your approach to patient education. How do you explain medical information clearly? Effective patient education is about bridging the gap between clinical knowledge and real-world understanding. It's not just what we teach, but how we ensure it resonates. My approach is rooted in health literacy principles, where I assess each patient's baseline understanding, learning preferences, and cultural context before tailoring explanations. For instance, when teaching a newly diagnosed diabetic patient, I begin by asking, what do you already know about diabetes? To identify gaps and misconceptions. Rather than overwhelming them with textbook definitions, I use relatable analogies, comparing insulin to a key unlocking cells for glucose, paired with visual aids like color-coded portion plates. With hands-on demonstrations, I employ the see one, do one, teach one method, first showing how to inject insulin, then guiding their hands, and finally having them explain the steps back to me. This not only confirms comprehension, but builds confidence. I'm mindful of cognitive load, breaking complex regimens into manageable chunks. A congestive heart failure patient might learn about sodium restrictions one visit, fluid monitoring the next. For low literacy patients, I replace medical jargon with plain language, water pill, instead of diuretic, and use teach-back techniques. Can you show me how you'll take these pills at home? Cultural sensitivity is paramount. When educating a Muslim patient about Ramadan fasting with diabetes, I collaborated with their imam to align medical advice with spiritual practices. With pediatric patients, I incorporate play, using stuffed animals to demonstrate asthma inhaler techniques. My documentation always notes the teaching method used and the patient's demonstrated understanding. The true measure of success? When a patient can articulate their care plan in their own words, like the hypertensive grandmother who proudly told me she tames the salty dragon by reading food labels, that's when education becomes empowerment. How do you handle cultural differences in patient care? Cultural competence in nursing requires more than awareness. It demands active curiosity, humility, and the flexibility to adapt care plans to align with a patient's beliefs and values. My approach is rooted in the LEARN model: listen, explain, acknowledge, recommend, negotiate, which I've applied in diverse settings from urban trauma centers to rural community clinics. For example, when caring for a Hmong patient with liver cancer, I recognized that her family's preference for herbal remedies wasn't refusal of care, but a cultural approach to healing. After listening to their perspective without judgment, I collaborated with the hospital's traditional medicine committee to safely integrate non-conflicting therapies while explaining how chemotherapy could complement their practices. This compromise, documented in the care plan, built trust and improved treatment adherence. I proactively educate myself on prevalent cultures in my community, such as learning that some Orthodox Jewish patients may decline nurse touch during Sabbath unless life-threatening. For a Bedouin woman uncomfortable with male providers, I rearranged assignments while explaining to colleagues how this preserved her modesty without compromising care. Language barriers are addressed through certified interpreters, never family members, and I verify understanding using teach-back methods tailored to health literacy levels. With a Somali diabetic patient, I used pictorial glucose logs and worked with a community health worker to address his belief that only sweet foods give strength. Crucially, I view cultural encounters as two-way learning. When a Filipino family insisted on feeding their intubated relative for strength, I researched and discovered this reflected a core value of pagmamalasakit, compassionate care. By blending their practice with our aspiration precautions, We created a safer feeding schedule the family supported. These experiences have taught me that culturally sensitive care isn't about memorizing customs, but developing a mindset that asks, what does health mean to you? Before assuming noncompliance. It's this philosophy that enables me to deliver truly patient-centered care across cultural contexts. Tell me about a time you went above and beyond for a patient. There was a moment with a terminal cancer patient, Mr. Alvarez, that profoundly shaped my understanding of compassionate care. Diagnosed with metastatic pancreatic cancer, he had been transitioned to hospice, but carried one unspoken regret: he hadn't seen his beloved spaniel, Max, in 3 months due to hospital restrictions. Recognizing how deeply this weighed on him, I coordinated with our infection control team, the hospice social worker, and his family to arrange a carefully planned visit. After confirming Max's vaccination records and designating a private garden area, we ensured Mr. Alvarez had adequate pain management before the reunion. That afternoon, as Max bounded toward him, the joy on his face transcended words. He later told me it was the first time he'd felt light in months. But what stayed with me wasn't just that moment, it was the ripple effect. His daughter, who'd been struggling to accept his decline, later shared that seeing him smile again helped her find peace. The experience even prompted our palliative team to draft a formal pet visitation policy for end-of-life patients. This wasn't about checking extra tasks off a list. It was about truly seeing the person beyond the diagnosis. Whether it's sourcing halal meals for a fasting Muslim patient or spending off-duty time teaching a homeless diabetic how to store insulin without refrigeration, these acts aren't extras to me. They're the essence of nursing, honoring what makes each patient human while applying clinical expertise to make it possible. How do you involve family members in the patient's care plan? Family involvement is often the bridge between clinical care and lasting recovery, so I approach it as a structured yet personalized partnership. My strategy begins with an intentional family assessment during admission, identifying not just who the decision-makers are, but also cultural dynamics, health literacy levels, and even logistical barriers like work schedules that might affect participation. For example, when managing a stroke patient's rehabilitation plan, I scheduled family meetings during his son's lunch breaks so he could participate. I provided simplified diagrams of brain recovery timelines and trained his daughter-in-law in mobility exercises using the teach-back method, ensuring she could confidently say, *. So we support his left side during transfers to avoid shoulder injury. * with their permission, I created a private family portal in our EHR where they could track progress and leave notes for the care team, a practice that reduced their anxiety and prevented duplicate questions. In sensitive situations, like a teenager's diabetes management, I balance parental education with the patient's growing autonomy. During family sessions, I might say, let's discuss how we can all support Maria's new carb counting skills while privately equipping her with discrete tools like a glucose monitoring smartwatch. For end-of-life care, I've found that ritual inclusion, whether helping a daughter apply moisturizer to her mother's hands or guiding a son through final oral care, gives families tangible ways to process grief. One memorable case involved coaching a Vietnamese grandson in gentle limb massage for his grandmother, respecting their belief that * loving touch guides the soul. *. Crucially, I document family input as rigorously as clinical data, noting preferences like no discussions after 8 p.m. when patient fatigues or * son translates medical terms to Tagalog for mother. This systemic integration ensures continuity across shifts and disciplines. By treating families not as visitors, but as essential collaborators, whether through structured training, flexible communication, or cultural rituals, I've seen remarkable outcomes, faster recoveries, smoother transitions to home care. and families who feel empowered rather than overwhelmed. How do you work as part of a multidisciplinary healthcare team? Family involvement is often the bridge between clinical care and lasting recovery, so I approach it as a structured yet personalized partnership. My strategy begins with an intentional family assessment during admission, identifying not just who the decision-makers are, but also cultural dynamics, health literacy levels, and even logistical barriers like work schedules that might affect participation. For example, when managing a stroke patient's rehabilitation plan, I scheduled family meetings during his son's lunch breaks so he could participate. I provided simplified diagrams of brain recovery timelines and trained his daughter-in-law in mobility exercises using the teach-back method, ensuring she could confidently say, asterisk. So we support his left side during transfers to avoid shoulder injury, asterisk. With their permission, I created a private family portal in our EHR where they could track progress and leave notes for the care team, a practice that reduced their anxiety and prevented duplicate questions. In sensitive situations, like a teenager's diabetes management, I balance parental education with the patient's growing autonomy. During family sessions, I might say, let's discuss how we can all support Maria's new carb counting skills while privately equipping her with discrete tools like a glucose monitoring smartwatch. For end-of-life care, I've found that ritual inclusion, whether helping a daughter apply moisturizer to her mother's hands or guiding a son through final oral care, gives families tangible ways to process grief. One memorable case involved coaching a Vietnamese grandson in gentle limb massage for his grandmother, respecting their belief that loving touch guides the soul. Crucially, I document family input as rigorously as clinical data, noting preferences like no discussions after 8 p.m. when patient fatigues or son translates medical terms to Tagalog for mother. This systemic integration ensures continuity across shifts and disciplines. By treating families not as visitors, but as essential collaborators, whether through structured training, flexible communication, or cultural rituals, I've seen remarkable outcomes, faster recoveries, smoother transitions to home care, and families who feel empowered rather than overwhelmed. Describe a time you had a conflict with a colleague. How did you resolve it? During a particularly demanding shift in the ICU, I experienced a disagreement with a senior respiratory therapist regarding the weaning protocol for a ventilator-dependent patient. I believed the patient was ready for a spontaneous breathing trial based on improving blood gases and alertness, while the therapist insisted on maintaining current settings due to concerns about rapid, shallow breathing. The discussion became tense when he dismissed my assessment with, I've been doing this for 15 years. Stick to nursing. Recognizing the patient's best interest was at stake, I requested a brief pause and suggested we review the data together at the bedside. Using the SBR, Situation Background Assessment Recommendation, framework, I presented my observations objectively. Mr. Khan's POW2 has been stable above 90 on 40% FiO2 for 12 hours, and he's consistently following commands. I'm concerned prolonged ventilation may increase delirium risk. Could we try a 30-minute trial with you monitoring closely? This shifted the conversation from authority to evidence. The therapist agreed to a trial under dual monitoring, and when the patient maintained excellent saturation, it became a turning point in our professional relationship. Later, I approached him privately to acknowledge his expertise in airway management while explaining how his initial comment had made me feel devalued. He apologized and admitted being stressed about another critical patient. We agreed on a 2-minute rule for future disagreements, pausing to summarize each other's perspective before deciding. This experience taught me that conflicts often stem from competing priorities rather than personal differences. By focusing on shared goals, using structured communication tools and addressing interpersonal dynamics respectfully, we transformed tension into a collaborative partnership that ultimately benefited our patients. How do you handle constructive criticism? I view constructive criticism as an essential catalyst for growth in nursing, where the stakes are too high for complacency. When receiving feedback, I practice the listen, reflect, adapt approach to ensure it translates into tangible improvements in my practice. Early in my career, a charge nurse observed that my patient handovers, while thorough, often included excessive detail that slowed down shift transitions. Rather than becoming defensive, I asked for specific examples and realized I was prioritizing comprehensiveness over efficiency. I then shadowed her during handoffs, adopted the ISBAR framework more rigorously, and within a week streamlined my reports without omitting critical data. This not only improved team efficiency, but unexpectedly enhanced my clinical reasoning. I learned to distill complex cases into prioritized insights. Now, I proactively seek feedback through weekly check-ins with colleagues and by reviewing patient satisfaction comments. When a recent audit showed my wound documentation lacked consistent photo updates, I immediately created a smartphone reminder system and studied best practices in visual charting. What matters most isn't that I make mistakes, it's that I demonstrate measurable progress after recognizing them. The most valuable lessons often come from unexpected sources. A nursing assistant once pointed out that my hurried morning med passes made elderly patients feel rushed. Since then, I've built 5 extra minutes into my schedule for brief socialization, which actually reduced call bell usage as patients felt more attended to. By treating feedback as collaborative rather than corrective, I've cultivated a reputation as someone who values excellence over ego, a mindset that aligns with the ever-evolving standards of international healthcare. What does professionalism mean to you in the context of nursing? To me, nursing professionalism is the seamless integration of clinical excellence, ethical integrity, and compassionate leadership, a commitment that extends beyond tasks to the very essence of how we represent the vocation. It manifests in 3 fundamental dimensions. First, accountability as a covenant, not just compliance. When I administer medications, I don't simply follow the 5 rights. I consider how a patient's cultural beliefs about pain might require me to adjust my explanation of side effects. After a near-miss error early in my career involving look-alike medications, I championed a unit-wide pause and verify protocol that reduced such incidents by 40%. Demonstrating that true professionalism means transforming personal lessons into systemic safeguards. Second, boundaries with heart. I've learned to balance empathetic connection with objective decision-making, whether comforting a grieving family while maintaining accurate death documentation or respectfully redirecting a physician's unclear order without undermining collaboration. This balance was tested when a patient offered an expensive gift in gratitude. I declined, but suggested they donate to our hospital's charity fund, preserving the relationship while upholding ethical standards. Finally, advocacy as a daily practice. Professionalism isn't static, it's speaking up when a policy contradicts best evidence, as I did when research showed our Foley catheter removal checklist was outdated. By presenting data to the Practice Council, we revised the protocol, reducing CAUTIs by 25%. It's also about appearance and demeanor. My scrubs are immaculate not for appearance's sake, but because a stained uniform erodes patient trust in our sterile standards. At its core, nursing professionalism is about embodying the trust society places in us, where every action, from hand hygiene to hard conversations, honors the privilege of caring for lives at their most vulnerable. Are you comfortable delegating tasks to other healthcare team members? Absolutely. I view delegation not just as a practical necessity, but as a strategic tool to enhance team efficiency and patient outcomes when executed thoughtfully. My approach is guided by the 5 rights of delegation: right task, right circumstance, right person, right direction, right supervision, which I've refined through experience in high-acuity settings. For instance, while managing a full patient load in the step-down unit, I recognized that a stable but mobility-limited patient required frequent repositioning. Rather than attempting this alone between complex med passes, I delegated turns to a CNA with specific instructions. Mr. Chin needs 30-degree lateral turns every 2 hours due to his sacral pressure injury. Let's use the lift sheet together for the first turn to ensure proper technique. This empowered the CNA while ensuring standardized care. I'm particularly mindful of competency matching. I wouldn't ask a newly floated tech to perform bladder scans without first verifying their training. When delegating to junior nurses, I employ the see one, do one, teach one method. Recently, I supervised a graduate nurse through her first 4 insertion, first demonstrating my approach, then observing her technique, and finally having her explain the steps to me, which reinforced her confidence and my oversight. Crucially, I follow the delegate, don't abdicate principle. Even when assigning tasks, I maintain accountability by conducting bedside spot checks, like verifying intake/output totals with the nursing assistant at shift end. This balance was vital during a code blue when I directed a volunteer to manage compressions while I prepared medications, then switched roles to assess effectiveness. Effective delegation requires emotional intelligence too. I've learned that some team members thrive with autonomy. You've got this. Just flag me if his O2 sat drops below 92%. While others need structured check-ins. By tailoring my approach, I've built trust that allows our team to function at full scope, ensuring patients receive timely care without compromising safety. How do you handle a situation where you disagree with the physician's order? When faced with a physician's order that raises clinical concerns, I approach the situation with a combination of respectful collaboration, evidence-based reasoning, and patient advocacy. My priority is always to ensure safe, effective care while maintaining a constructive team dynamic. For example, I once cared for an elderly post-op patient who was ordered a routine NSAID for pain management. While reviewing her chart, I noticed her creatinine levels had been gradually rising, and her history included stage 3 chronic kidney disease. Recognizing the potential risk of acute kidney injury, I prepared for the conversation by gathering relevant data, current labs, the hospital's NSAID protocol for renal patients, and alternative analgesic options. I contacted the physician using the SBR, Situation Background Assessment Recommendation, format. Dr. Lee, I'm calling about Mrs. Gupta in 412. Her creatinine has increased from 1.8 to 2.1 over 48 hours, and she has known CKD. The NSAID you ordered may exacerbate renal impairment. Would you consider acetaminophen or a reduced-dose opioid alternative? I've noted she responded well to tramadol during her last admission. When the physician initially dismissed my concern, the dose is low enough to be safe. I respectfully persisted. I understand your perspective. However, our renal protocol suggests avoiding NSAIDs when creatinine exceeds 2.0. Could we reevaluate after retesting her renal function this afternoon? This data-driven approach led to the order being changed to a safer alternative. In situations where urgent action is needed, I've employed the 2-challenge rule, voicing my concern twice with escalating urgency before formally escalating through proper channels. What's crucial is maintaining professional respect. I focus on the clinical facts, not personal opinions, and always follow up to understand the physician's rationale when possible. These experiences have taught me that appropriate questioning of orders isn't just a right, but a responsibility. Studies show nurse interventions prevent numerous medication errors annually. By combining clinical knowledge with diplomatic communication, I've built relationships where physicians now frequently seek my input on complex cases. What are your understanding of the LPN scope of practice? My understanding of the LPN scope of practice is rooted in three key pillars: regulation, collaboration, and clinical judgment. As an LPN, I recognize that my practice boundaries are defined by state nursing boards, institutional policies, and the dynamic needs of patient care, all while working under the supervision of RNs or physicians. Fundamentally, LPNs serve as the clinical bridge between CNAs and RNs, with our expertise lying in hands-on patient care, focused assessments, and stable condition management. For example, I routinely perform tasks like medication administration, including IV therapy in many states, wound care, and data collection such as vital signs and intake/output monitoring. However, I'm acutely aware of the limits. I don't initiate push medications for critical conditions, perform initial nursing assessments, or develop comprehensive care plans, though I actively contribute to them by reporting changes in patient status. A nuanced aspect of our role is situational awareness. While I can't independently triage in the ER, I've identified early sepsis in long-term care residents through meticulous monitoring and promptly alerted the RN. In hospice settings, I've managed comfort care protocols, but always consult for changes to the plan of care. I maintain strict competency boundaries through regular skills validation and policy review. When floated to a new unit, I immediately clarify which skills are within my scope there, like whether I can insert catheters or administer blood products. This vigilance protects patients, my license, and the care team's integrity. Ultimately, the LPN scope isn't just about tasks. It's about knowing when to act, when to consult, and when to escalate. This understanding allows me to practice confidently while ensuring seamless teamwork for optimal patient outcomes. A patient refuses to take their medication. How would you handle this situation? When a patient refuses medication, I approach it as an opportunity to understand their perspective while ensuring they make an informed decision. My process balances respect for autonomy with professional responsibility for their safety. First, I pause and assess non-judgmentally, using open-ended questions to uncover the root cause. For example, when an elderly COPD patient refused his bronchodilator, I knelt beside his chair and asked, "Can you share what concerns you about this medication?" He revealed it made his heart race last time. By verifying his vitals beforehand and offering to administer it slowly with pulse monitoring, he agreed to try it. For patients with cognitive impairments, I adapt my approach. A dementia patient who kept spitting out her antibiotics responded well when I disguised it in pudding and used positive reinforcement. This will help your tummy feel better. Let's have your favorite music after. With cultural or health literacy barriers, I employ teach-back methods with visual aids. A Haitian diabetic patient refusing insulin due to beliefs about weakness accepted treatment after I collaborated with a Creole interpreter to explain how it complemented her herbal teas. If refusal persists despite education, I first document thoroughly exact refusal reason, education provided. Second, notify the prescriber for alternatives, e.g., transdermal versus oral. Third, reassess later. Many patients reconsider after processing information. Crucially, I never take refusal personally. A teen's "I hate these pills" became adherence when we switched to liquid form and tied doses to his gaming schedule. By treating each refusal as a unique puzzle, I've turned many no's into collaborative yes. You notice a change in a patient's vital signs that seems concerning. What steps would you take? When I detect abnormal vitals, My response follows a systematic, patient-centered approach that balances urgency with clinical reasoning. First, I immediately validate the findings, repeating measurements with proper technique, e.g., ensuring correct cuff size for BP, while assessing for equipment artifacts. For example, when a post-op patient's SpO2 dropped to 88%, I first checked for nail polish interfering with the probe before escalating. Simultaneously, I perform a focused assessment tailored to the vital sign changes. A sudden tachycardia, HR-130, would prompt me to evaluate pain levels, using the appropriate scale, check for bleeding, and assess lung sounds, as I did recently when discovering a patient's muffled breath sounds and falling BP signaled tamponade, requiring stat pericardiocentesis. I then apply the ABCDE framework: airway, breathing, circulation, disability, exposure, to prioritize interventions. For a febrile patient, 39 degrees Celsius, with rigors, I initiated cooling measures while reviewing their foresights for phlebitis and culturing potential infection sources, a protocol that identified early sepsis in a diabetic ulcer patient last month. Communication follows the ISPAR format. *Dr. Lee, this is Mihiraa. Mr. Khan in 412 has developed hypertension, 180/110, with new headache and blurred vision. His history includes CKD and missed dialysis. I've elevated the HB and dimmed lights. Request your review for possible hypertensive urgency. *. While awaiting orders, I implement standing protocols within my scope, administering O2 for hypoxia, positioning for orthostatic changes, or giving prescribed PRN meds. I document everything in real time, including trends from prior shifts that might indicate deterioration. Crucially, I stay with unstable patients until help arrives. When a stable CHF patient's RR increased to 28 with silent wheezing, I remain to monitor while calling the rapid response team, preventing full respiratory arrest. Every abnormal vital is a puzzle. My role is to interpret clues while mobilizing the team to act before numbers become crises. A family member is very upset and demanding about their loved one's care. How would you respond? When faced with an emotionally charged family member, my approach centers on de-escalation through empathy, active listening, and collaborative problem-solving. I begin by creating a private space for discussion, stepping away from the bedside or nurse's station to minimize distractions and protect the patient's dignity. Recently, a daughter became visibly distraught when her mother's pain medication was delayed during shift change. I knelt to meet her eye level and said, *I hear how worried you are. Let's talk about what's most concerning right now. By reflecting her emotions, this delay must feel like we're not prioritizing your mom. I validated her feelings without defensiveness. As she explained her mother's past trauma with uncontrolled pain, I realized her demands stemmed from fear, not hostility. While she spoke, I firstly identified non-negotiables, immediate pain relief. Secondly, clarified misunderstandings, explained the safety checks causing the delay. Thirdly, co-created a solution, administered the order dose while securing an order for scheduled meds to prevent future gaps. For ongoing concerns, I involved the care team strategically. With a son insisting on unproven alternative therapies for his father's cancer, I arranged a family conference with the oncologist and palliative team, ensuring medical guidance was delivered with cultural sensitivity. I document such interactions thoroughly, noting both the emotional context, daughter expressed guilt about care decisions, and clinical actions taken. This ensures continuity when colleagues interact with the family later. What transforms these moments is remembering that families are extensions of the patient. Their distress often mirrors their loved one's suffering. By addressing the fear behind the anger, I've turned confrontations into partnerships, like the wife who became our unit's most vocal advocate after we incorporated her husband's favorite hymns into his dementia care. You make a medication error. What is your immediate course of action? When a medication error occurs, my response follows a patient-first, system-oriented protocol that prioritizes safety while ensuring transparency. The moment I recognize the mistake, whether giving the wrong dose, medication, or time, I immediately pause and assess the patient's condition, staying with them to monitor for adverse effects while calling for clinical support if needed. For example, when I once administered 10 milligrams of morphine instead of the ordered 5 milligrams to a post-op patient, I first stabilized the patient, stayed to monitor respirations and O2 saturation, prepared naloxone, and elevated the HB to prevent aspiration. Second, alerted the team, used the SBAR format to notify the physician. Dr. Lee, I gave Mrs. Chen 10 milligrams morphine 4 instead of 5 milligrams at 14:30. Current RR is 10, SpO2 94%. Request orders for monitoring and reversal if indicated. Third, documented transparently, filed an incident report within the hour, detailing the error, interventions, and patient response without defensiveness. Fourth, disclose to the patient/family, explain the error and safety measures in an empathetic, non-alarming manner. I gave an extra dose of your pain medication by mistake. We're monitoring you closely, and I've notified the doctor to ensure your safety. Post-event, I participate in root cause analyses to identify system gaps, like the time our unit implemented barcode scanning after my near miss with lookalike vials. I also conduct a personal reflective practice, reviewing protocols to prevent recurrence. This approach aligns with just culture principles, acknowledging human error while improving processes. By responding with accountability and urgency, I've transformed errors into opportunities to strengthen both my practice and institutional safety nets. You suspect a colleague is not following proper infection control procedures. What would you do? If I observe a breach in infection control protocols, my response balances patient safety, professional accountability, and respectful collaboration. I recognize that lapses may stem from oversight, knowledge gaps, or systemic barriers rather than intentional neglect, so I approach the situation with a problem-solving mindset rather than confrontation. For instance, when I noticed a fellow nurse repeatedly skipping hand hygiene between patient rooms during a busy shift, I first ensured it wasn't a perception error by discreetly observing over multiple interactions. At an appropriate moment, away from patient areas, I initiated a private conversation using non-accusatory language. I've noticed how swamped we've been today. Sometimes in the rush, it's easy to forget hand sanitizer. I've caught myself almost missing it too. Can we remind each other? This framed the issue as a shared commitment rather than personal criticism. If the behavior persisted, I would escalate through proper channels, first to our charge nurse with specific observations. Yesterday, I saw 3 instances of glove reuse between patients in room 412. Then to infection control if unresolved. During a norovirus outbreak, I once collaborated with our IPC team to implement visual reminders at sanitizer stations after noticing consistent PP shortcuts. Crucially, I consider contextual factors. A new graduate struggling with proper doffing might need mentoring, while chronic noncompliance may require formal retraining. I also self-reflect, could workflow design contribute? After identifying that our medication cart's location encouraged corner cutting, I proposed a repositioning that reduced cross-contamination risks. My goal is always to protect patients while preserving team trust. By addressing lapses as system challenges rather than individual failures, I've helped cultivate a unit culture where we gently correct each other without shame, because safe care is our collective mission. How do you maintain ethical standards in your nursing practice? Maintaining ethical standards in nursing requires a commitment to integrity, advocacy, and continuous self-reflection, guided by frameworks like the ICN Code of Ethics and Institutional Policies. My approach is both proactive and responsive, rooted in daily habits that prevent ethical dilemmas, while also preparing me to navigate them when they arise. At the foundational level, I safeguard patient autonomy through informed consent practices. For example, when administering a new medication, I don't just verify the 5 rights, I ensure patients understand the purpose, risks, and alternatives in culturally sensitive terms. With a recent Somali patient hesitant about blood transfusions due to religious concerns, I coordinated with interpreters and her imam to align medical recommendations with her beliefs, documenting her decisions meticulously. Confidentiality is non-negotiable. I adhere to HIPAA/GDPR standards by discussing sensitive information only in private settings, using secure messaging for electronic communications, and redacting identifiers when presenting cases for training. When a colleague once joked about a patient's condition in the elevator, I politely redirected the conversation and later reviewed privacy protocols with them, addressing the lapse while preserving our working relationship. When faced with moral distress, such as a family demanding feudal care for a terminal patient, I employ a structured response. 1. Consult ethics committees to explore alternatives. 2. Advocate compassionately for the patient's documented wishes. 3. Debrief with mentors to process emotional tolls. I also recognize that ethical practice extends beyond patient interactions. During the pandemic, I anonymously reported a supplier's attempt to upsell counterfeit PPE, upholding justice for both patients and colleagues. Regular ethics journaling helps me identify personal biases. After realizing I'd assumed an unhoused patient would miss appointments, I implemented reminder calls that improved his adherence. Ultimately, ethical nursing isn't static. I stay current through ANA ethics webinars and case study discussions with peers. By anchoring decisions in the 4 principles, autonomy, beneficence, non-maleficence, and justice I ensure my practice meets both regulatory and moral obligations. Questions to ask to the employer. What is the typical patient-to-nurse ratio on this unit? What are the opportunities for professional development and continuing education here? What is the team culture like? What are the main challenges an LPN might face in this role at your facility? What are the expectations for a new LPN in the first few months? What type of orientation and training is provided? What are the opportunities for advancement within the organization?